lifestyle medicine, see how you're doing in each of those pillars, and then coming up with a treatment plan that we both work on and agree on, and see where you're motivated, where you're not motivated, how to motivate you, what barriers to remove so that you can achieve optimal outcomes in your MS journey. So again, I am available Monday through Friday, and it could be virtual or in person. Typically, I spend an hour with each of you, sometimes longer. Don't hesitate to call the MS Center, or you can send a MyChart message to me, Adrienne Castillo, and let me know that you're interested in scheduling for a brain health clinic visit. And just a reminder that Thanksgiving is about, I think, 22 or 24 days away, and Christmas is like 50 days away or something less than that. And I know there's a lot of prep and planning in regards to the holiday season, but what have you prepped and planned for self-care in regards to the holiday season? It's important to talk about it because it's a stressful time, and it doesn't have to be a time where you go off your routine or you gain 10 pounds. It could be very different. So just please contact me and let me know when you're available, and we'll meet. But thank you and enjoy the webinar tonight. It's always great working with anyone and everyone.
Thank you, Adrienne. Appreciate that. And I'll make sure if you could in the chat box, maybe just let folks how they can actually reach you and make an appointment with you. So if you wouldn't mind putting that in the chat box, that would be appreciated. And Jules, if you could just give us a brief introduction in your role there at Rush.
Absolutely. So again, my name is Jules, and I'm one of the clinical research coordinators at Rush. I work very closely with our providers to do things like collect patient-reported outcomes. And several of you may have already met me to do things like this. So I'll collect questionnaires from you, basically. And I work in conjunction with the Brain Health Clinic and the rest of our providers to kind of help gauge how you're doing and any changes that do occur. So for instance, if you come into the clinic, your chief complaint is fatigue, for instance. There is a questionnaire that you could fill out at that appointment, and then in a few months, you would complete this questionnaire again while implementing those changes that you and Adrienne, for instance, discuss, and we'll kind of see if you've had any changes that you've reported. So that's an example of what I do currently at the clinic.
Fantastic, Jules. Thanks so much. And last but not least, of course, Allison, we want to hear from you about this exciting study that is happening there at the University of Illinois in Chicago. If you could tell us a little bit about METS, this mood and exercise study.
Yeah, so my name's Allison Wathen. I'm one of the research coordinators that works out of our exercise and neuroscience research lab here at the University of Illinois, Chicago. And our lab is focused on a wide variety of topics, but the vast majority of the studies that we have running right now are for folks with MS. And essentially our focus is on getting folks moving. We know from the research that the more you guys move, the better off you're going to be, both in terms of your motor function, but also in terms of your mood. And so the study that I am the research coordinator on is looking at the effects of exercise on folks with multiple sclerosis and symptoms of depression. So we are currently enrolling, and We are looking for folks that are able to get around independently. So folks that aren't using any kind of assistive devices. You got to live in the Chicagoland area. Anything else we'll sort through if you get in contact with us. But essentially what you would be doing is one of two customized, randomly assigned exercise programs. All of the exercises have been made for folks that have multiple sclerosis and can be tailored based off of your individual needs. So if you have pain or weakness on one side of your body, if you have spasms in one of your arms per se, you have lots of drop foot in one or both of your feet. These are all things that previous participants have had and we have worked around and can help with. So essentially, if you're interested in participating in any kind of research regarding exercise and multiple sclerosis, we have a study for you. So if you want to get in contact with us, you can always email me and I'll put my email address into the chat as well. Or you can visit us at enrl.uic.edu. I'll put that into the Dropbox as well. And you can look at all of the different research projects that we've currently got going on. We also have our outreach coordinator. I know, I'm sorry. We do have studies that are inbound. They have not gotten their approvals yet, but we have a few studies that are inbound for folks that are using assistive devices. And we do have a couple of partners in our PT department that one has a study up and running for folks using assistive devices, and one has one that should be up and running in the next couple of months. So I can give you more information about those studies as well. So you are not being left out. I promise you, we have things for you. And I will drop everything in the chat. And if anyone wants to get in contact with us, I can also spread you to whichever team might be a better fit for you if for whatever reason depression is not an issue you face. So please get in contact with us. And yeah, if you have any questions, just let me know.
Fantastic, Allison. And I do have to say the University of Illinois in Chicago has been running some really fantastic studies when it comes to looking at exercise in conjunction with other symptoms, MS symptoms. So we're super happy to have you, tell the larger MS community about some of these wonderful studies you folks are working on. So thank you, Allison, for sharing that with folks. Well, and Dr. Augusto Miravalle, it is your turn to take over and give us a little bit of an update on what came out of ECTRIMS. So I will turn it over to you. Oh, and before we do so, sorry, folks, I do want to make sure if any questions do pop up at any point in time, please be sure to put that into the chat box or the Q&A. I will be monitoring that, so don't be shy. Please do ask any questions you might have. Thank you.
Thank you, Kathy, and thank you, Adrienne and Jules, for all this wonderful work you're doing at the Brain Health Center at Rush. And also, Alison, thank you for sharing your research studies with Dr. Model's lab. So without further ado, I just want to share my screen so we can start looking at exciting research updates that were presented during the last version of ECTRIMS. As Kathy mentioned, this is the largest MS conference in the world, and over 8,000 scientists and neurologists participate. And this is a wonderful way to share information, get updates, and also stimulate discussions for future studies. So I decided to just tailor some of the topics that I know are of interest. I've been talking to some of you, and you have provided some information on what are the topics that you would like to hear from me today. So let's go. Let's start here. So the first category is the use of highly effective therapies. So multiple studies have been published before, and you can see some of those are from 2021. And we had some updates on long-term efficacy. Basically, the story here is when you use these highly effective therapies that are listed there, which is ocrelizumab, rituximab, natalizumab, and then the study included other drugs like mitoxantrone and alemtuzumab, which are no longer used. So these highly effective therapies, these infusions, when used earlier, they make a difference. So the earlier you use them, the better the effects they have in all these clinical outcomes, whether it's lesions or disability progression. And you can see the red line is using them late. The blue line means using them early, whether it's as the first treatment or at the beginning of the disease onset or waiting for 6 years after. So the earlier you use them, the better it gets. So, I know that some of you may have had MS for many years, and maybe the question you have is like, wait a minute, if I had MS for 30 years, are these medications still effective? Well, that might be a challenging question to answer, and that always I say, well, talk to your neurologist and make sure that every time you see your healthcare team, they assess and they be able to answer that question. So that's one of the excitement that was discussed. And this is another follow-up study looking at something we call NEDA, or no evidence of disease activity, which means no relapses, no lesions, and no progression. So when you put all three outcomes together and you measure how are these medications helping patients to stay in that NEDA state. In the past, we used to call that in remission. So meaning nothing is happening, right? No lesions, no relapses, and no progression. And you can see the red bars are the medications that were studied. The green bars are the comparators, whether it's interference or placebo. So interference in green, placebo in gray. You can see that by default, these highly effective therapies. So the first two ones are Ocrevus, then you go to cladribine, and then you have natalizumab, fingolimod or Gilenya, and then Tecfidera. So you can see that all of these therapies are better than the comparators or placebo. But again, those highly effective therapies, they tend to do better when it comes to preventing disability as well as to keeping patients in remission. Something that is important also, the caveat that is there in red on the top, these studies were not designed to compare these drugs with each other, so these are independent studies. So please don't make the mistake that some of us do of saying, oh, one showed 48 in one study and the other one shows 37. That means that the 48 is better. Well, no, we can't say that because the studies were designed differently. The patients enrolled were different, so we truly cannot compare across trials, and we shouldn't. But it's nice to see a trend, and the trend is that these highly effective therapies tend to do better. So the other area of interest is stem cells, and I know that some of you ask questions about stem cells. So I thought to start by clarifying few concepts. One is this concept of continuous or chronic immune suppressions. And that means, we administer medications to chronically suppress immune responses. And that is actually 90% of the drugs that we have approved. So the infusions that we were discussing before, the oral medications than, Gilenya or Tecfidera, Ocrevus, Tysabri. So those are medications that are given on a regular interval with the goal of chronically suppressing immune responses. So as you can see here, these arrows are the drug administered, then the drug is present in the body, and then the clinical efficacy is durable over time. So, but then there is another way to treat MS, which is what we call intermittent immune suppression. So these are medications that are given in short intervals, and then they're removed. And the effect, the durable effect of the medication lasts for many years. And currently there are two approved medications that have this mechanism, which is cladribine or Mavenclad and alemtuzumab or Lemtrada. So alemtuzumab is not, it's not frequently used these days just because of safety, but Mavenclad is one oral option that is frequently used. But then a stem cell transplant falls into this intermittent immune suppression. So those are interventions that are given once at the beginning and then never again. And the goal will be to have a durable effect. So I thought to start there just to get a sense of where do these stem cell transplant fit into the algorithm of care. So, and here you have two kind of words that are also important to describe. So one is what we call the autologous hematopoietic stem cell transplant. That's a mouthful to say these are your own cells. So we remove your cells from your bone marrow, we manipulate them a little bit, and then we'll reintroduce them. So those are your own stem cells. Then there is another type of stem cell transplant that is the allogeneic. That means that those stem cells come from donors, from other humans. Those are not your own cells. So the area that is being developed the most is what is called the autologous hematopoietic stem cell transplant, the one in red. And within that category, there are two ways that we can use these stem cells. One is by decreasing or debulking inflammation. And so what we do is, again, we manipulate these cells and we eliminate the ones that are reacting against your body. And the other way that this intervention helps is by the so-called resetting or rebooting the immune system. So if you have an immune system that is autoreactive, well, let's eliminate all the immune cells. Let's just take the ones that we don't want and let's reintroduce. Similar to what we do with the computer when the computer is not working. We'll just reboot the computer hoping that the new version of it is going to be less autoreactive. So that's kind of like the very general concepts of why we are thinking about stem cell transplants in the context of MS. So I will not walk you through this, but hopefully the visuals tells you the story. And the story is that this is very complex. So anywhere from the removal of the stem cells to harvesting the cells that we want to keep, eliminating the cells that we want to get rid of, to keeping the patient safe. Imagine if you're not having these immune cells in your body, you're going to be prompt to a lot of infections and complications. And then the storage of these cells, and then the transplantation of these cells, it takes months and sometimes years. So this is not a simple process. And as you can imagine, in every step along the process of stem cell transplant, there could be complications, including death. And that's why perhaps you're seeing that it's taking a little bit longer to conclude on how and when to use this therapy, because it's not free of side effects and safety concerns. And I'm going to pause here to say, if you're considering stem cells, please make sure that you do it in a place that is safe and reputable, because I know that there is a lot of tourism and of stem cells in the world that happens to be in cool places that we want to vacation, but may not be the safest places you want to have this type of treatments. So please be safe. Please talk to your healthcare team if you're considering this type of treatments. So again, and after we introduce these cells, they're not going to altogether differentiate into the type of cells that we want. And that process takes time. So this gives you another sense of, once you reintroduce these cells into someone's body, then these stem cells have to become the cells that you want, whether it's T cells, whether it's B cells. And even within these cells, this compartment of T cells and B cells, they have to become its own subsets. Imagine going back to the police, right? So you have a problem in the Chicago police, and you say, I'm going to eliminate everyone, anywhere from the police officers to the higher rank of officers in the police station. And then you bring all new people. Well, they need to be trained. They need to get to the ranks that they were before, and they need to know how to work with each other. So that whole process takes months up to years. And one of the things that could happen is that some cells may differentiate before. Imagine that all of a sudden, go back to the police example, and you have the lower ranks officers develop first, and then they are functioning without supervision. They're functioning without anyone telling them what to do. So there is this potential of doing the wrong things. And one of the most common side effects, or not common, but most concerning side effects of stem cell transplantation is the development, listen to this, are you ready? Of autoimmunity. And you might be like, wait a minute, how is that possible? We are treating autoimmune disorders. We are getting the immune cells out. We are retraining them, putting them back. How is that possible that it's going to create autoimmunity? Well, The reason being, all of these new cells, if they develop before the so-called regulatory cells, the ones that keep things on check, they have the potential to become autoreactive again. So that's why it's important to understand this complex process. It's not simple. And one of the paradoxical consequences of stem cell transplantation is the development of autoimmunity. And then this is just to show you that all subtypes of cells may come back in a different formula, and which could help MS. And that's one of the hopes, that if you know that MS, the chronic portion of MS, is driven by these memory cells, the ones that they remember to go after the wrong target, in this case, myelin. Well, as you transplant stem cells, you're going to lose most of those memory cells, which is great for MS, but is not good for things like vaccinations. So if you have your childhood vaccinations to mumps and measles and rubella, well, your memory cells are the ones keeping you safe. If all of a sudden you eliminate them, you have to revaccinate to all of that stuff again. So there are all these consequences that happen when you do this type of stem cell transplantation. But having said that, it's still exciting, and we are still looking at this as a potential option. So it's not all negative, but I want to start with those caveats. So big consequences in terms of negatives is that repopulation of cells may lead to autoimmunity, and also you have to revaccinate patients because you're losing that memory cells. In MS, may be a good thing because those memory cells are the ones that perhaps infected by Epstein-Barr virus, the virus that causes mono, are the ones you want to get rid. So that's a whole hope of this. So bottom line, several studies have shown efficacy, this effective, and I'm going to show you one example of that. One study looked at the use of this stem cell transplantation compared to standard therapy, not highly effective therapy, but standard therapy, and it showed that was better. And there are currently 4 randomized controlled trials looking at stem cell transplantation against therapies, and one of them, which is perhaps the most interesting, called Beat MS, is looking at stem cell transplant against highly effective therapies. Remember what I told you early on, those are the best therapies we have. Well, can we compare the two? So we are excited to wait for those results. Probably we won't have the results until later 2025, early 2026, but that's going to give us a final answer, hopefully, whether this is worth it or is not better than what we have as the highly effective therapies. Even before the studies, we have evidence from the so-called real world, and that means patients that actually underwent stem cell transplantation. And on ECTRIMS, they presented the data from over 2,100 patients. Most of these patients came from Europe, and most of those patients came from the UK, which is very frequently used. And this just shows you that those patients were older in general. They had all sorts of MS, whether it's relapsing or progressive MS. They used it for primary progressive, for secondary progressive MS. And those were patients that actually did not respond to traditional therapy. So patients that actually had advanced disease with some disability. As you can see, an EDSS of 6 already means using a cane. So most of these patients were either using a cane or using, I see Susan's question. So Selma Blair is using Mavenclad. So it's the medication that I mentioned before. And then what did they found? Well, safety-wise, 4 people died. And the number of patients that died was 4 out of 363, which are the ones that they have data for. So it was a high rate. And those deaths were directly related to, at least 3 of them were directly related to the transplantation. One was on day 0, so the very first day that they received that, the patient had an imbalance in electrolyte and it resulted in cardiac arrest. And 2 patients died from sepsis in the first month and the second month, and 1 patient died from a fatal accident, subarachnoid bleeding in the brain, and cardiac arrest. So this just to show that even in those well-controlled places, death and mortality is a concern. How about benefits? Well, it did show benefits. So you can see that 94% of patients were free of relapses by the second year, and 88% of patients were free of relapses by the fifth year. In terms of MRI activity, 88% of patients did not have any activity on MRI at the second year, and 78 at the fifth year. So again, we shouldn't compare across trials, but this is not that different or better than what we see with highly effective therapies. So what else did these do? Well, let's talk about progression-free survival. So how many patients were free of any type of progression? 83% of patients at the second year and 62% of patients at year 5. Not amazing, but actually is good outcomes. And then how many patients reached NIDA, that state of remission, was 72% at the second year and roughly 50% by year 5. This is comparable to what we have currently with the so-called highly effective therapies. So is that for death justifiable? Probably not. But something to keep an eye on is what is called the incidence of improvement. So how many patients improve? And this is something we want to keep an eye, because it might be the reason to use this or consider use this in the future, because you can see these numbers are impressive. So 24% of patients at the second year and 26% of patients at the fifth year improved. And again, those are patients that had high disability to begin with. So keep an eye on this. I think that's perhaps the most exciting part of stem cell transplantation, is not only this concept of durable benefit, but also perhaps look at improvement. Just for context, even those highly effective therapies that we have now maybe offer a 7 to 10% improvement rate. So this could be substantially bigger than what we've seen with highly effective therapies. So here's another website for you, and we can put it in the chat box, is clinicaltrials.gov. So if you want to know more about clinical trials in MS, this is a wonderful resource. There is a search engine on the top, and you can type MS, and then the second search engine, you can type, for example, stem cells, and then you click enter, and I will give you all of the clinical trials in the world, not just in the US, in the world, that are looking at stem cells in MS, alongside with the information on how to apply the inclusion criteria. So it's a great tool in case you get inspired by all of these talks and you want to say, you know, where is this happening? And I want to know more. All right. Kathy, any questions before I jump to the next topic?
Yeah, and I think some of them you did address while we were moving forward in your presentation, but one that just came through from Peter is the BEAT trial allogenic or autologous cells?
It's autologous. So the BEAT trial is looking at your own stem cells.
Okay. And question around, is tinkering with the regulation still too dangerous or not possible?
I'm sorry, what?
Tinkering with the regulation around, I guess, these studies still too dangerous or not possible?
Oh, no, in terms of regulation from ethical standpoint, I guess, or political sometimes get involved. So no, this one is not as controversial because we're not talking about umbilical cord, fetal stem cells. These are your own cells. So you're not dealing with any of these ethical controversies on other type of stem cells. So that whole area is what we call the mesenchymal stem cell research. Which is, I think, is fascinating from a scientific standpoint, not as advanced when it comes to MS application.
And the last question was, is HSCT best for relapsing remitting versus progressive?
Yeah, great question. So more than the type of MS, I think the HSCT was going to be a matter of timing. When is that administered? Whether it's primary progressive or relapsing, it truly doesn't matter. But what it does matter is how soon after onset of disease. And even though we've seen some improvement in patients later on in the course, all of the studies that are being done now are trying to look at earlier interventions, saying if we can reboot this whole system before MS progresses, can we truly see that durable or curable effect, right? Which is what we hope. So I think it's going to be more a matter of timing than type of MS.
Excellent. I think those were all the questions related to this particular section of your presentation.
Very good. All right, let's move on. So So, Peter, I see a question. It went too fast, Kathy. Can you read Peter's question?
Is meant when you mentioned sometimes cells don't mature to work, so is looking at controlling the regulation or maturing possible?
Great question, Peter. So both. So all of these different protocols are having a different type of way to not only harvest the cells, but also differentiate them or eliminate the ones you don't want. So they're part of the studies are looking at how to better repopulate these cells into someone's body to ensure some sort of predictable rate of repopulation. So you don't get into surprises of saying, oh, geez, the effector cells came before the regulatory cells, and all of a sudden you don't know what to do. So part of the research is looking into that. So my advice is, well, if you're good with your therapies, probably wait, because there are so many unknowns into this stem cell research that probably is not worth the risks.
Excellent. I think
All
some of
right.
the other questions we can probably wait to the end because
Good.
they're not related
Okay.
to that particular topic.
Good. How about new therapies? Well, there was a big announcement of a BTK inhibitor called tolebrutinib, which is an oral therapy. And actually, this study was positive, meaning good results, in a subgroup of patients that we don't have a lot of studies for and we don't have options for, which are patients with progressive MS without relapses, without MRI activity. So the patients with secondary progressive and primary progressive MS, so include both, that do not have relapses and do not have MRI activity, but yet they continue to worsen. So it was a great study because it truly looked at a population that we don't have much to offer. Just as a background information, BTK is this enzyme called Bruton tyrosine kinase. And this enzyme is inside our favorite cells, the B cells, but also is inside another cell that we are paying attention to called the microglial cells. So the microglial cells are inside the brain. And these cells are the ones that may be involved with a lot of chronic inflammation in MS. That inflammation that causes atrophy, the inflammation that expands those lesions. And so by having one enzyme that is present in two types of cells, we hope that to kill two birds with one stone. And I don't know if that phrase is controversial anymore, but basically what you're doing is targeting one enzyme that is present in two targets. And those two targets are critically important in MS. So that's why we are so excited with BTK inhibitors. And the other thing that is exciting about this drug is that it's oral, means that it crosses the blood-brain barrier. So with one medication, you can hit inflammation outside the brain and inflammation inside the brain. Wonderful concept. Now there are 5 or 6 BTK inhibitors that are currently being studied. The first one that brought up information was evobrutinib last year, and unfortunately didn't meet the primary outcome. But they did not study that medication in a chronic progressive MS population. They only study in acute MS. And actually, the results were really good, but it was not better than the comparator, Aubagio. So for that reason, the FDA is not going to approve it because in this day and age, you have to be better. Otherwise, what's the point? But unfortunately, they didn't study the drug in progressive MS. So this medication that works very similarly was studied in both acute MS, relapsing MS, as well as progressive. So in the relapsing MS, the same story didn't look better than Aubagio. But in the progressive MS, looked good. And that's what I'm going to share with you now. So 60 milligrams daily, 1 tablet a day versus placebo. And they included patients up to 60 years of age, so a little bit older than the usual clinical studies that usually are up to 55. And they include patients with a disability more than the cane, so a little bit worse than using a cane. So they did go into patients with high levels of disability. And so they looked at these outcomes. So disability progression at 6 months, disability progression at 3 months, disability improvement at 6 months, and then they looked at the usual lesions and brain volume and side effects. So most patients were in the late 40s, which is again something different to what we are used to. So a little bit older population than most of the clinical trials that we've seen. Most patients had disability that was around the cane, and they had MS for at least 17 years. So you can see those are older individuals with long MS. And so how did that do? Well, it was a 31% reduction in progression of disability at 6 months. And even though that may sound like little, it's actually a lot. So 1 in 3 patients did not progress of disability. And again, those were patients that were having progression despite being on something else. And that was not due to relapses or not due to MRI. So this may be a number that actually may truly change the game. So how about 3-month disability progression? Well, the same thing, was a 24% reduction. And then how about improvement? Was a 10% improvement. So remember what we were talking before with stem cells was around 24, 26. So not quite as there, but actually there is some improvement of disability that is happening here. So all good, but what about lesions? Well, these start to become a little bit less clear on the benefit. So the annualized lesion reduction was better, but not to the numbers that we are used to in the highly effective therapies, but did have an improvement. In terms of brain volume, improved the rate of atrophy, but not different to placebo. So this is where things start to get a little bit less clear on the benefit. Perhaps we need more time, perhaps we need or database or data points. But when you look at the actual rate of atrophy, it was similar to what we expect from healthy aging. So things that still we are scratching our heads to try to understand, well, what I mean, how is that possible that disability was better, but brain atrophy didn't change? So we're trying to understand, but this is what we have. Side effects. Well, for the most part, patients tolerated the medication very well. They were 15% of serious side effects compared to 10% on placebo. So you can see the numbers are relatively comparable. However, this is the big one. So liver function abnormalities is something that we need to check. And if this drug gets approved, will require monitoring with weekly blood tests for up to 3 months. So there's a little bit of a commitment here because liver function elevation could happen. And there were a few patients, but significant number of patients that had up to 20 times more the number of enzymes that healthy control. So 20 time elevation is serious, could be potentially life-threatening. As a matter of fact, one patient required liver transplantation and died due to consequences of this. So it's something that is not free of side effects. It's rare, but because of that rare occurrence, that will require very close monitoring of this liver function abnormality. So a blood test a week, probably for 90 days. And most of these, actually all of these abnormalities happen in the first 3 months of therapy and did not happen after. So at least we have a little bit of a relief of knowing, well, if this happens earlier, at least we can rest assured that won't happen later. So yes, it does affect B cells, but does not deplete them. So it's not like Ocrevus or Briumvi that actually eliminates the B cells. This just inactivates them. This prevents the B cells from causing inflammation. But patients remain with B cells, which is another big difference to kind of killing B cells. So, and that's why infections perhaps are not going to be seen as much. So yes, big improvement, 31% reduction in disability progression versus placebo. Also improvement on disability, improvement of disability by 10%. For the most part safe, except these liver function abnormalities that we need to keep an eye on that. And most of these abnormalities were self-limited, except those serious ones, of course, and we probably will have to monitor patients frequently. Yet to be determined whether this is going to be approved, and if this approved, how frequent that monitoring will have to happen. probably it's going to be weekly. All right, Kathy, what questions do we have?
Yes, and I'm reading through this right now. I'll start with the one that just came through. Do you see these BTK inhibitors being used in older patients than in their 40s, so to speak? So, and how many years out would you guess we are from seeing this category available?
Yeah.
So, yeah.
Both excellent questions. So let's start with the second one. No, probably soon. So now that the phase 3 trial is being released, the data has been released. Now it's a matter of the FDA to review the data and decide on approval or not. And that could happen as early as first semester next year. So if this gets approved, probably we will be having this available in next year. So that piece is exciting. In terms of when to use that, excellent question. So probably when you look at the mechanism of action and the benefit is something that we will be using later. So the current thought behind that, and this is just all expert opinion from colleagues of mine that we talked about this pretty frequently, is like, well, let's use highly effective therapies, those anti-B-cell therapies perhaps earlier to stop acute inflammation as much as we can. And then as patients age and as the disease continues to be stable, then we can use these BTK inhibitors mostly as a maintenance therapy to try to prevent that chronic inflammation. And, from a safety standpoint, once you pass the first 3 months of the liver abnormalities, safety is actually pretty good. So probably is going to be something that we can sequence after the highly effective therapies, but this is all speculations.
Excellent. Question here from Sarah. Is tolebrutinib a medication that would be taken alongside B-cell depleters or instead of?
No, it will be monotherapy instead of. But as I mentioned before, probably the sequencing will be interesting. Saying, maybe a couple of years, 5 years of anti-B-cell therapies, maybe followed by, oral therapies for the rest. So something that we are still trying to understand. And of course, as you can imagine, there are going to be ongoing studies trying to answer that question. Now that we have this option that is filling a void, a gap that we have in our current therapies, how do we combine it with the ones that we have? And of course, we can do them together, but we can sequence them in a way that makes sense when you look at the mechanism of action and how they affect MS pathology.
And here's a question from Sarah regarding BTK inhibitors. Is there any reason that this method of treatment is being more effective towards female patients given X chromosome loci?
No, it's just the studies, because they kind of follow the demographics of MS. The studies looked at more females, so you have more females enrolled in the clinical studies just because MS is more frequent in females. This is not the only one that is being studied. There are other clinical trials that are looking at other types of BTK inhibitors that differ in many ways that they work. And so we may start to see a little bit more differential or preferential effect on gender, but it's something that, again, we continue to learn.
There is a question about remyelination, and I know that's a great segue to your next section because I think that's what you're going to be talking about. But there were 2 other questions ultimately, and I think this one really could potentially depend on the patient themselves. In your opinion, which available DMT is the best one to be using? And again, I will turn that one over to you, knowing that that's a big question.
That's a big question. And to be honest, I don't think anyone that actually gives you an answer is going to give an honest answer, because we can't say that. At the end of the day, personalized medicine is what we advocate for. It's what is best for you, what is best for your circumstances, for your story. And that's why we need to know you. We need to learn, what happened to you in the past, how your MRI looks, your physical exam, because all of those things matter. So we can't say that one drug is better than the other one. Having said that, what I call as these highly effective therapies that are the B-cell depleters, and natalizumab, ocrelizumab, Kesimpta, Briumvi, Mavenclad. So all of those drugs actually consistently showed higher efficacy than other class of medications. So I will probably say, those what we call the highly effective therapies.
Thank you. And I guess this may be the last one before we jump into your last section here. Thoughts on Pursuis trial and when we will see results. Are you familiar with that one, Dr. Miravalle?
So those are also BTK inhibitors. So we had the Hercules and Perseus. So the Perseus trial was the active relapsing MS, and that was actually presented as well in ECTRIMS. And that's the one that I briefly mentioned did not meet the primary outcome compared to Obagio. So, but the Hercules, which is in the secondary progressive and primary progressive, it did the primary outcome.
Excellent.
So
Well,
the last section is my favorite because at the end of the day, we're talking about brain health. And of course, being on a highly effective therapy is one component of brain health. Access to healthcare is another component of brain health. And that's why at Rush, we have a new pledge for 2025, which is 80% of the requests for new patients will be offered a visit within 7 days of request. Let me say it again, 7 days of request. So if someone calls and says, I want to see an MS neurologist, they will be offered an appointment within 7 days. And we have that pledge that 80% of the patients or more will be the case. So we are working very hard. Last year, we were at 79.2%. So I think we are very close to meeting our goal. And we are hiring a new neurologist. And that new neurologist is Ali Osen. Ali is going to join us in 2 weeks. She's our former fellow, so some of you may know her from when she was doing her training, and she's coming back to Rush. And in the next conversations on brain health in December, we'll introduce her to you. And so we're hoping that not only Ali will bring so much value because of her interest and expertise, but also help us improve that access to care so everyone can have meaningful, timely, and appropriate access to healthcare. Last but not least, lifestyle interventions. So a lot of interest. So gut microbiome had like multiple sessions, and this is a really cool picture from an AI-generated microbiome. Just to remind us that we are full of bacteria. We are superorganisms. We are colonized by all these little tiny things in our gut that actually do a lot of things for us. Most of that is good, but sometimes it's bad. And guess what? We can modify that based on what we eat. So here there are 3 examples of what is called healthy microbiome in A, dysbiotic microbiome, so bacteria that are pro-inflammatory and that increase inflammation, and bacteria that actually decrease anti-inflammation. So it's kind of like a double negative. So you can see that the healthy bacteria has equal amount of the good cells in blue, the Treg cells, or the bad cells in red, the Th17. So how do you have a healthy microbiome? Guess what? Diet. If you eat healthy, you have happy bacteria in your gut. So if this is the reason why we talk about nutrition here. That's why we have Adrian Castillo doing a brain health clinic to talk to patients about how to change your diet, how to modify your diet. So if you eat healthy, you're going to have happy bacteria and you're going to regulate your immune cells. You can see that if you eat unhealthy, those trans fats, the bacons of the world and the burgers and salt, I mean, all the things that we know are bad for you is going to increase the amount of pro-inflammatory cells or red cells called the T helper 17, bad cells for you, and it's going to decrease the regulatory cells, the blue cells, the good ones for you. And by the way, we are a day away from elections, so the colors has absolutely no political meaning here whatsoever. It's just the way the slide was presented to me. So we know that certain, so MS patients have more representation of certain bacteria. And those are the ones here in red. And those bacteria, independent of diet, so maybe just due to the fact that patients have MS, there is this predisposition of having more of these bad bacteria, the bacteria that actually causes inflammation. So more so, it's important to have a healthy diet, because kind of MS patients are already starting with an overrepresentation of certain bacteria that may be pro-inflammatory. Another interesting data that was released is that the presence of these bacteria is directly linked to MRI changes. And think about, you have the bacteria in the gut, and yet it's causing lesions in the brain. So there is a direct relationship between the inflammation that is causing, that is perhaps a consequence of this colonization of bacteria, and lesions in the brain. It's also related to things like cortical lesions and the lesion of brain volume. So, and last but not least, this was something that was presented earlier in 2023 and was confirmed in 2024, which is this bacteria called Clostridium perfringens. It's a mouthful, but this is another example of a bacteria that not only increases inflammation, but actually was seen, listen to this, was seen within the lesions in the brain. So not only is present in the gut, but somehow this bug managed to get all the way to the brain and be around the lesions. So something, again, that goes into this concept of MS is not caused by just a single thing, it's a combination of factors. And the gut microbiome, the bacteria that we have in our gut, is one of those factors that contributes to that. So Sarah, so yes, so these studies looked at stools, and they measure what bacteria are present in stools as a way to determine the colonies that an individual patient may have. So another update was these factors that we already know that contribute to MS. So this is risk of developing MS. So smoking, whether it's directly or passively smoking. So any number that is more than 1 in the second column contributes to the disease. Any number that is less than 1 is protective. And you can see that, exposure to solvents or Epstein-Barr virus infection, vitamin D deficiency, sun exposure, meaning low sun exposure, childhood or adolescent obesity, night shifts, that's again goes back to the lack of sun exposure. Those are factors that actually contributes to a higher risk of MS. The ones that didn't show, or actually show some protective, is the oral nicotine, and I don't want to endorse this yet because I think more studies are needed. But physical activity, again, it goes back to the exercise. The more people exercise, the less risk of multiple sclerosis. Alcohol, the same thing. I need to know what is happening there. Cannot be possible that alcohol is protective, but more to learn there. And then coffee, another thing that appears to be protective. How much of that leads to socioeconomical factors? The arguments here, like, well, people who can afford coffee and alcohol perhaps have also better health care, and that's why they have less chances of all of these diseases happening. But again, those are things that we are still trying to understand. Physical activity, again, early physical activity decreases the overall risk of MS. So if you have family members that are young and they're asking you, what can I do to decrease my risk of MS? Exercise, and exercise. Exposed to sun, perhaps wear sunscreen if you worry about skin cancer, but check your vitamin D levels. Don't smoke. Keep a healthy weight. So those are things that we know that will protect them from or decrease the risk of MS. And I have a minute left. A lot of interest in remyelination. Unfortunately, nothing groundbreaking. So we are still waiting for that holy grail of remyelinating therapies. I did a conversations on brain health last January, I believe, Kathy, or February, I can't remember, but it was nearly a year ago, and nothing new has been released since that conversation. So I will invite you to watch it if you want to learn more about it. That's pretty much where we are. And with that, I'm going to stop sharing and answer any additional questions.
This is an interesting question. That was just towards the end here. Did you learn anything new, or have you formed any opinions on type 307?
Yeah, no. So it is a medication that is it's one of those remyelinating therapies. So it's an antihistamine. It goes under their muscarinic receptors. And it's one of those drugs that actually was discovered through this high throughput of medications to try to refurbish or repurpose medications. So no updates yet, but it's something to keep an eye on because it could have potential remyelinating effects. But no updates.
Okay. Question is, why are our taste buds working with bad bacteria to make foods with salt, sugar, unhealthy fats, etc. so appealing? Ha ha ha.
Yeah, so that is critical. And I saw a question about prebiotics, probiotics. So yes, so if the ideal answer will be just eat healthy. But sometimes you need a little bit of a boost. Let's say you had a UTI and you received antibiotics, and we know that the oral antibiotics can hurt some of that microbiome. So I think it's appropriate to take more prebiotics and probiotics. So remember, the prebiotics is the food for the bacteria. The probiotics is the bacteria itself. So you're doing both. So I think that will be, a good application of probiotics. You can, of course, take it every day if you want to. There is nothing wrong with that. But if you eat healthy, right, Adrian, you're the expert here on lifestyle interventions.
Yes, I saw a question from Mark, if taking probiotics is okay. It's okay, but the best practice is to eat healthy, and good bacteria feeds off of fiber. So vegetables, fruits, your multigrains, and all of those categories are in the Mind Diet, which I talk about all the time with patients.
Fantastic. Here's a general question, just around MS in general. Does it matter at what age you had mono?
Yeah, so the studies that looked at the effect of mono in MS show the strongest association in patients that develop mono after the age of 15. So it's that later exposure to mono that appears to have an effect. And you may think, well, wait, isn't mono the kissing disease? Why will someone get mono when they are 4? Well, actually, in underdeveloped countries, in third world countries, the incidence of mono infection occurs very early in life, and that has nothing to do with kissing. It's just the fact that it could be transmitted through other practices as well, and poor hand sanitation and hygiene is one of those. So the US is one of those countries that perhaps due to good sanitation that we have, in a sense, the incidence of mono increases as we get a little bit older into our teens. And, it's a fascinating area in MS called the hygiene hypothesis that explains why certain autoimmune disorders, MS included, occur in places with better sanitation. And that has to do with perhaps the fact that, the earlier our immune system is exposed to pathogens, the more nuanced it gets to prevent autoimmunity. But yes, when you look at Epstein-Barr virus, the highest linked to the infection with MS risk is in those individuals who were exposed after the age of 15.
Fantastic. And I know, Maram, you had a question for Allison that you had popped into the chat box at the beginning. You said you would let us know after Dr. Miravalle is finished. So I didn't know if you wanted to put that in the chat box still real quick. Otherwise, there was a real quick question around MOGAD, and evidently MOGAD was a hot topic at ECTRIMS. You can maybe just briefly speak about that since we are already 3 minutes over.
MOGAD stands for myelin oligonucleotide glycoprotein associated disease. It's a disease that in the past used to be confused with MS, but now we have an antibody that actually it tells us that it's a different type of disease. So a lot of medications. So currently we don't have any approved medication for MOGAD, but we use a lot of medications from the MS indication. And there are some exciting therapies, including satralizumab, which is an interleukin-6 inhibitor that is being studied for MOGAD. So stay tuned. And I forgot to tell you another news, but it's more for your information. So the diagnostic criteria for MS, called the McDonald criteria, gets periodically updated. And the last version of it, the 2023 version, was presented in last ECTRIMS in 2024. So we now have a brand new criteria for the diagnosis of MS. Probably none of you will be undiagnosed with MS because it's not eliminating previous diagnosis, but it's adding the possibility to diagnose MS to people that perhaps in the past did not meet criteria for MS. So an example of that is people with normal MRIs of the brain. So in the past, we used to say, no, you have to have lesions in the brain in order to be diagnosed with MS. Now, with lesions in the spinal cord alone, if you meet certain clinical criteria, we can establish a diagnosis of MS. So that was another exciting news. Probably won't change much for this audience, but it's good to know.
Fantastic. And I just unmuted Miriam so she can actually ask
Yeah.
a question real
Thank
quick
you.
too.
Yeah, thank you, Kathy. I actually got the email of Allison. I will be emailing her, but because of the conversation that I'm seeing here, my question is to you, Kathy. Is it possible to create a group like Telegram? I will create it and you can send it to everyone so that people can jump in, because it seems like a lot of people have a lot of questions.
Regarding this particular webinar?
No, not this webinar. All the MS people in Chicago, the one that attend Rush.
Yeah, no, I'm always happy to get the word out of anything that is going on and is of
Okay.
interest to the MS community. So, I mean,
I'll send it to you.
folks
I'll
know how
email
to
you.
reach me, right? So you
Thank
can
you.
always email me anytime.
Thank you. Have
You
a
also
good
have a different answer for the bacon question. Dopamine and serotonin are major factors with eating. So if you are someone who finds salty or sugary foods more comforting, you're going to tend to go back to those foods when you're maybe discomforted. And so your brain feeds off of those patterns. So the more you do them when you are unhappy or dealing with issues in your life, the more likely your body is to crave those when you're having similar feelings in the future.
Good point, Alison.
Yeah. Yeah. Well,
Very good.
fantastic.
Plus, they're delicious.
Well, Kathy, I pass it on to you.
Yes, well, I think this was fantastic. Thanks so much, Dr. Miravalle, for providing us all that wonderful information on ECTRIMS. And Allison, thank you for giving us insight into the studies there at the University of Illinois in Chicago. Adrienne, Jules, always happy to have you join us as give us a little bit of insight as to what's happening there at Rush. So I think this was fantastic. Thanks so much. This was recorded and will be available if anybody does want to go back and hear any of the information at a later date. We will have it on the Rush YouTube channel. You can always reach out to me if you're having a hard time finding it, and I'd be more than happy to send it out to you. But hope everybody has a wonderful evening, and we'll see you next month. Thanks so
And
much.
don't forget to vote.
Thanks, Allison.